Got
Thank
it.
you.
You're welcome.
All right. I'm going to start sharing my screen. I think Dr. White has given everyone these slides. Can everyone see my PowerPoint? Just a thumbs up. Okay, Dr. White gave me the thumbs up, so here we go. Let's see here. We'll do it this way. All right, so like Dr. White said, I am Tyler Walsh. I'm the PGY2 geriatric pharmacy resident, and today we're going to start talking about blood pressure, and then Dr. Strain will move into blood glucose monitoring. So here's the learning objectives. We will classify normal and critical blood pressure and blood glucose, identify factors that influence blood pressure and blood glucose, and you will demonstrate the appropriate technique to obtain blood pressure and blood glucose from a patient. So that's what you will be doing on Thursday in the Clinical Skills Center. So for blood pressure, your equipment, you're going to have a stethoscope and a sphygmomanometer. So the stethoscope is what you'll use to listen with, and the sphygmomanometer is the blood pressure cuff that you'll put on the patient. So for the stethoscope, you have the earpieces that will go in your ear, the tubing, and then the bell and the diaphragm that is used to listen. For the sphygmomanometer, you have the cuff, the bulb that you use to inflate the cuff, a valve that allows air to go in and out of the tubing, and then the manometer. So for the stethoscope, when you put your stethoscope in your ears, you want to make sure that the earpieces are forward facing, not backwards. If they're going back towards your ear, you won't be able to hear anything. So make sure they're forward facing in your ear, like this diagram right here. For the end of the stethoscope, you have the bell, which is the smaller side, and it's used for, like children and higher frequency sounds. And then you have the diaphragm, which is what we'll use to hear lower frequency sounds. So this is what gets placed on the patient's arm to hear the sounds for the blood pressure. So in addition to the stethoscope, your cuff or your sphygmomanometer, you need to make sure that you have the proper size. So it comes in multiple sizes. There's different sizes for children and for adults. So make sure that you have the right size cuff for the patient that you're taking the blood pressure for. So on here you see that there's a range. So that is where, when you wrap the cuff around the arm, that this line, this index, should fall. So when you're putting this on someone's arm and you wrap it around, you want to make sure that the index falls within the range. And I hate that we're on Zoom and I can't show you this in person, but you see the index line is falling in the range right there. Okay? I know that's probably really, really hard to see, but it'll make more sense on Thursday. And also, there's this artery mark, or on mine it says like left arm, right arm. So that's where you line up the cuff so you can hear the sounds when you're taking the blood pressure. And we want to make sure the blood pressure cuff is snugly fit on the patient's arm, but you also want to be able to put 2 fingers under the cuff just to make sure it's not too tight. All right, so for the patient interview, whenever they come into the room and you're going to take their blood pressure, you want to ask about recent caffeine and tobacco use, as well as their medications, because after all, we're pharmacists. So we'll ask about prescription medications, specifically antihypertensive or high blood pressure medications, and OTCs, such as decongestants and analgesics. So my question to y'all is, what factors cause your blood pressure to be increased? Feel free to unmute your mic and talk to me. I love when people talk to me. Stress, okay, good.
Pain.
Higher water intake.
Okay.
Food. Salt.
Or exercising for extended periods of time.
Okay, good. Anybody else?
Caffeine.
Caffeine, yeah. So that's all right. So decongestants, exercise, pain, anxiety, a cuff that's too small. So if you're using a child's cuff on an adult patient, and then caffeine and tobacco, those can all cause the blood pressure to be increased. So on the flip side of that, what can cause your blood pressure to be decreased?
Histamine.
Okay.
Fatigue.
Okay.
Blood thinners.
Why do you say blood thinners?
Honestly, that's just a wild guess. It sounded right.
Okay. Okay. Anybody else want to take a stab at it? Okay. So alcohol, antihypertensives, analgesics, and a cuff that's too big, so using an adult cuff on a child, would cause the blood pressure to come back as low. So with blood thinners, those don't typically, we wouldn't think that they would lower the blood pressure necessarily. Those are more going to keep from the blood sticking together and causing a heart attack or a stroke. So the main prescription medications that we want to think about are the antihypertensives or high blood pressure medications. All right, so whenever you bring your patient into the room and you're ready to sit down and take their blood pressure, there's a few things that you need to be aware of for positioning your patient. So you kind of talk to them, ask them the questions, now you're getting ready to take their blood pressure. You need to make sure their feet are flat on the floor, no legs crossed for ladies, no ankles crossed, they need to be flat on the floor. Their arm needs to be resting at heart level, so if they're sitting at a table like in the picture, then their arm is at heart level. Their back needs to be supported by a chair, so they don't need to be laid back, they don't need to be standing, they need to be sitting with their feet flat on the floor, arm propped up on a table, and their back supported by a chair. They need to rest for about 5 minutes because, like we said on the previous slide, exercise can cause your blood pressure to be high. So even walking from the waiting room to the exam room can cause their blood pressure to be elevated. They need to be quiet and still because moving or doing any kind of movement, so even talking, can give an abnormal blood pressure reading. And you need to ask them, have you had any caffeine or tobacco in the last hour? Because again, that will cause the blood pressure to be high. And also ask them about if they do take antihypertensives, ask them when their last dose was. If it wasn't within the last 30 minutes to an hour, then their blood pressure could be higher.
Dr. Walsh, can I ask you a question?
Yes.
So what if you go in to take someone's blood pressure and they say that they just had a massive cup of coffee?
So that's okay. We can still take their blood pressure. We just need to know that it's going to be high, and that's probably not their, blood pressure if they were just at home.
Okay.
So, if their normal is 138 over 86, but they've drank, Starbucks on the way to the clinic, and they come in and it's 160 over 90, it's, we're not going to freak out. We're just going to document and make sure the patient understands, yes, your blood pressure is higher, but it's because of this. You had coffee, you had caffeine. So it's patient education as well. Super important.
All right, thank you.
Good question. Any other questions? Hearing none. So sometimes I talk really fast, so if I am talking too fast, just let me know, okay? All right. So prior to taking the blood pressure, you've got the patient in the room. We're going to find what we call the pulse obliteration pressure. And this is to help you avoid overinflation of the blood pressure cuff. So once you determine the proper cuff size, you've placed it on the arm, it's not too tight, you're going to palpate the radial pulse. So just find the radial pulse. So that is on the wrist, thumb side, because the radius is rad, remember, from anatomy. If they have a watch on like I do, they'll need to remove it so you can feel their pulse. When you find the pulse, inflate the cuff rapidly to about 80 millimeters of mercury, and then continue to inflate the cuff in increments of 10 millimeters of mercury until the pulse disappears. So at that point, once the pulse disappears, you'll deflate the cuff at about 2 millimeters of mercury per second until the pulse returns. And when the pulse returns, that is considered your pulse obliteration pressure. So for Thursday, whenever you determine what the pulse obliteration pressure is, make sure that you verbally say that, so the P4 that is checking you off can put a check next to that, okay? And this is going to be super important, like I said, to avoid overinflation of the cuff. Any questions on pulse obliteration pressure? That's usually a newer concept for people.
Okay, so can you go over radial pulse, please?
Yeah, so radial pulse. So in the arm, there's the radius and the ulna, the bones. So radius is rad, so it gets a thumbs up. So the radial pulse will be on the thumb side. So you'll just palpate with 2 fingers until you feel their pulse right in here on the wrist. Okay? And on Thursday, the checkoffs, it's to make sure that y'all understand how to do all of this that I'm verbally telling you today, so we can practice more, if that's something you're having trouble with, okay? Does that make sense? Does that answer your question?
So once we put on the cuff, we have to feel the radial pulse disappear?
Yeah, so you'll put the cuff on, find the radial pulse, you'll inflate it to 80, and then inflate it by 10 millimeters of mercury until you don't feel it anymore. Then you'll slowly deflate the cuff, and when you feel it again, when you feel their pulse again, that's going to be your pulse obliteration pressure. Okay?
Thank you.
Yep, no problem. What other questions do y'all have?
So I had someone teach me how to do this, and she was a nurse. And she told me to inflate it to 220 and then slowly let it out and read it. Is that incorrect?
Yes, so we never want to inflate a blood pressure cuff over 200. That is extremely dangerous for our patients, so we're not going to go over 200. So we're going to go to 80 rapidly and then by 10. But if you get to 200 and you can still feel their radial pulse, then you need to stop. We don't want to inflate it over 200 at any point in time. Good question. What else? Hearing none.
Is there anything special you have to do for like patients that have pre-hypertension or hypertension already?
So no. So you're just going to know that their blood pressure is going to be higher, and the reason we're probably taking it is to monitor that, to see when they get to the hypertension stage, and we would need to initiate medications if they're not already on any. Good question. Do I have language? Okay. Alrighty. Any other questions about pulse obliteration pressure, or any questions about checking blood pressure in general before we move on? No, I'm doing good. Okay, perfect. So we've talked about kind of placement and picking the size of the cuff. So we want to make sure that it's directly on the skin. So if they have a short sleeve shirt, just roll it up to their sleeve. We'll want to align that artery mark with their brachial artery. So the brachial artery is the artery that's right here, kind of in the crease of your elbow. So you have the brachial artery and the radial pulse. So brachial, radial. Okay. It is also called the antecubital place on your arm. So I might use that interchangeably. If I confuse you, please let me know. So when you put the cuff on the patient, it should go about 1 inch above the elbow, the crease of the elbow, or the antecubital space. So about 1 inch above right there. I'm trying to show you all on Zoom and it's not going very well. So about 1 inch. That's where the cuff goes. Your stethoscope, it's going to be off-centered from the brachial artery, but it's going to be towards the body. So towards their trunk. It's going to be off-centered. You'll place the head of your stethoscope about 2 to 3 centimeters above the crease of your elbow. So about right at the bottom of the cuff is where your head of your stethoscope will go. Okay. So here's a little diagram to kind of show you. So here's their antecubital space with their brachial artery, and then that their stethoscope is slightly off-centered just because of the way that the arteries run in the body, okay? And then here's where you'll palpate the radial pulse. Okay. What questions do you have about placement of equipment on the patient's arm?
So the artery mark will go on the brachial.
Right. So like with mine, it says left arm or right arm. So whatever arm you're doing, you'll want to line that up. But then on the picture, a couple slides back, it just has like a little circle with a line through it, and that's what you would line up with the brachial artery. Does that make sense?
I turned off my mic. I'm sorry. It does make sense.
Okay, perfect. What other questions do y'all have? Y'all have good questions.
This might be kind of a dumb question, but are you supposed to be able to see their brachial artery like through their skin, or are you supposed to just kind of know what general area it's in?
No, you'll just know the general area that it's in, that antecubital space, or right above the crease of their elbow. So whenever you inflate the cuff and cut off the artery, then you'll be able to hear the sounds as you slowly open the artery back up, okay? So you'll just know that it's in this general area right here on their arm. Good question. All right. So I keep talking.
I have a question.
Yeah, go ahead.
The point of feeling their pulse if you can hear it with your stethoscope, because you're going to 80 anyway, and you're increasing it bit by bit, so you're gonna hear it anyway eventually. So why are you?
So we have to get that pulse obliteration pressure to know how high to inflate the cuff to be able to get an accurate blood pressure. So we have to know about what pressure the artery is completely occluded or closed off, and that way we know how far that we can inflate the cuff to get the most accurate blood pressure. Does that make sense?
Yes.
Okay. It'll make more sense in a couple slides too. So if you are still confused, just let me know, okay?
All right.
All right. So I keep talking about these sounds that you're going to hear up here in the antecubital space. So they're called carot cough sounds. I've practiced that word all weekend to make sure I could say it appropriately. So you're going to hear about 5 different sounds, but they're going to be pretty hard to differentiate the phases. So all you're going to listen for is the first sound that you hear. That would be their systolic pressure, or the top number when you report the blood pressure. And then when the last sound you hear when it goes away, that's the diastolic pressure, so the bottom number on their blood pressure. So you'll start off and you'll hear just a faint tapping sound, and then you'll hear a little bit of a swoosh, like when a basketball goes through the hoop. Then you'll hear a loud knocking sound. Then it'll get kind of muffled, like it's going away, and then just quiet, just silence. And that's how you'll know. So systolic is going to be that first sound you hear. Diastolic is the last sound you hear, okay? And these are very hard to hear sometimes, especially with the double-headed stethoscopes like we will be using on Thursday. So just do your best. It takes practice to be able to hear these sounds, so don't get frustrated. I was not an expert the first time that I did this. It takes practice, okay? So I'm gonna see if this YouTube video will work, and we'll practice on listening to these sounds, okay? Can you see my screen? Can you see the YouTube video, or you still see the PowerPoint? You see the YouTube video, okay. So I'll make this bigger. Okay. You still see the YouTube video? Yes, no, maybe.
I just see it pop.
No, it's just your slide.
Okay, let's see. Resume share. That's mine. Okay. I'm going to stop sharing, and then we're going to reshare this. Okay. Okay, now you can see YouTube, yes.
Maybe it's a white screen right now.
There we go. I can see it now.
You see it now? Okay, perfect. So I don't know how well this is going to work. Like I said, these sounds are very hard to hear. So I apologize if it doesn't work, but we're going to try it anyway, okay? So just listen very closely. All right, could y'all hear that? Kind of, sort of. Okay. Do I need to play it again for anybody?
So if the question is, what was their blood pressure, then yes, I'm going to need to see that again. Also, I can see that it's jumping, like, obviously. Am I supposed to rely more on the sound or the visual cue that I see?
We want to rely on the sound the best that we can. All right. So I know it's really hard to hear, so y'all just try to see if you can tell me what their blood pressure is, okay? Here we go.
Like 120/78.
Okay, anyone else want to take a guess?
108/78?
Okay.
121/70?
Okay.
I was going to say 120/74.
Okay.
At 122/78.
Okay. Anybody else before I tell you the answer?
Over 80.
Okay. So Madeline, you were the closest. It was 122/76. So the link is in your slide set, and I can always email it to y'all as well, so you can, listen to it again. Okay. So let's stop sharing, and let's go back to the PowerPoint. Just a second.
And to clarify, the 122 is when it first opens up, and the 76 is when you last hear the pulse, right?
Correct. Screen sharing has failed. Correct. So when you inflate the blood pressure cuff, you completely close off that brachial artery. As you slowly reopen it, it just kind of starts to open and you start to hear a sound. And then when it's silent, that means it's completely open. So you're not getting a sound from it being so shut off. Does that make sense? All right. Back to this. So down here, there's the link. I can always email it out. But 170 or 122/76 was the answer. And there are lots of videos on YouTube. This was the one that I thought we could hear the best to listen to in class. All right, so the proper technique when you're checking your blood pressure or checking the patient's blood pressure is you'll inflate the cuff rapidly 20 to 30 millimeters of mercury above the pulse obliteration pressure. So that's why we have to check the pulse obliteration pressure. We don't want to overinflate the cuff, because if we overinflate the cuff and cut off that artery too much, then we risk it bursting. And that would just be bad all around. So 20 to 30 millimeters of mercury above the pulse obliteration pressure. So if their pulse obliteration pressure was 100, you would go somewhere between 120 and 130 whenever you inflated the cuff. So once you've inflated the cuff, not over 200, we cannot go over 200, so remember that. Stay under 200. You'll deflate the cuff again at a rate of 2 millimeters of mercury per second. So on this valve, if you turn, when you're holding it, if you turn it clockwise, that closes it off. So you'll turn it counterclockwise, and that opens it up. The problem that I know a lot of people have is when they close it before they inflate the cuff, they close it too much, and then they can't use their thumb and index finger to open it up, and they have to let go of the stethoscope and open that up. So just be careful. You don't have to, turn it as tight as it goes. Just turn it till you feel a little bit of resistance, and then it'll be super easy to open it back up, okay? So when you hear the first sound, that's going to be your systolic pressure. After you hear that last carot cough sound, you'll rapidly deflate the cuff at about 20 millimeters of mercury per second. I just opened the valve all the way up, and that's pretty much 20 millimeters of mercury per second. So you'll want to make sure that you remove the cuff from the patient's arm, and you'll report the blood pressure to the patient, because most people like to know, what their blood pressure was after you've taken it. So what questions do y'all have about how to take a blood pressure?
What if you go over over 40 millimeters of mercury of pressure? Like, would that still be okay?
Yeah, so that would be okay as long as you're not going over 200, but we really want to try to stay in that 20 to 30 range. That's why we kind of have that range. So, if you push the bulb too hard and it goes just a little bit over 30, that's fine. But we don't want to go 50 millimeters of mercury over their pulse obliteration pressure. So try to stay in that 20 to 30 range, okay? What else?
There's a question in the chat about what if the patient reports numbness or discomfort? Okay, that's a good question. So if they say that it's too tight and if they're feeling numbness, I would go ahead and deflate the cuff and just maybe try the other arm. Ask them if they think it was because the cuff was too tight, which is if you inflated the cuff and it was too tight, you might have the wrong pulse obliteration pressure. So there's lots of factors that go into that. Some people don't like getting their blood pressure taken and say the cuff is too tight, and it's just because they don't like it. They don't like something squeezing their arm. So you just have to be ready for that, okay?
Could the discomfort and numbness cause an inaccurate reading?
So
It depends on, I would say that it depends
Possibly.
how freaked out they get.
Mm-hmm.
So if they start getting very anxious about it, that can increase their blood pressure. If they start fidgeting, that can increase their blood pressure. So it could.
Okay.
So that's why we have to make sure they're still and quiet. And whenever you put the cuff on and you make sure that it's not too tight, you can put 2 fingers under there comfortably. Most people will be okay, and it shouldn't get too tight. Just make sure you don't overinflate the cuff. That's super, super important. Good questions. What else?
How long do you have to wait in between the obliteration pressure and then actually taking their blood pressure?
Good question. So 1 minute. We want to wait about 1 minute because we're inflating the cuff on the same arm. So if you take a blood pressure, inflate a cuff on the same arm multiple times, that can lead to problems if you're occluding that vessel over a lot in a short amount of time. So we wait about a minute. I always tell people, and this is how I practice, is if I take the blood pressure and I need to take it again for some reason, I always try to just switch arms, just so I'm not occluding the same vessel over and over again. Good questions. Right, so tips for success. Use the proper cuff size because that can lead to an inaccurate reading. Don't overinflate the cuff. Make sure you know that pulse obliteration pressure. Report the readings in even numbers. And we do this because if you look at a manometer, it only has even numbers. So you can't begin to guess an odd number. So only report even numbers, no odd numbers. You'll wait about 1 minute between determining the pulse obliteration pressure and checking the patient's actual blood pressure. Make sure whenever you go to check the blood pressure that the cup is completely deflated and the valve is closed. So clockwise to close the valve, counterclockwise to open the valve. And then make sure your earpieces of your stethoscope are in your ear the correct way, okay? Let's see. So interpreting the results, we have the systolic and the diastolic. Systolic is when the heart is pumping. Diastolic is when the heart's at rest. So normal is less than 120 over less than 80. And then when to notify a pharmacist or a preceptor if you're at a screening is if their systolic is 180 or more and or their diastolic is 110 or more. So it can be either or it could be both of these numbers. But if you see these numbers, or if you think that this is their blood pressure, or it's higher than either one of these numbers, let someone know because that's going to lead to an emergency. All right, so what questions do y'all have about blood pressure?
I have one. Whenever we're reading the numbers, whenever it's jumping like this, do we count when you hear the beat? Do we count the bottom one or the one that it jumps to in that split second?
It's a good question. So I would say the one that it's on and you hear the sound and then it jumps, the one that it's on is what you'll read.
Gotcha. Thank you.
Okay. What else before Dr. Strain talks about glucose?
There's a question in the chat about what is the acceptable margin of of error in a reading.
So we'll do about 4 millimeters of mercury plus or minus for systolic and for diastolic. So that's your margin of error is 4 plus or minus. All righty. Well, I'm going to turn it over to Dr. Strain, who is going to talk about blood glucose. Dr. Strain.
Okay, can you guys hear me okay? You can just give me a thumbs up. Awesome. Okay, again, so my name is Madisyn Strain, and I'm the second year ambulatory care resident at UAMS with the College of Pharmacy. And today I'll be talking to you guys about blood glucose monitoring. I love how interactive you guys have been so far, so if you have any questions, just feel free to stop me. Also, let me know if you can't hear me at any point. I'm a little quiet sometimes, so just feel free to let me know. And Tyler, next slide. So to get started, we'll first just cover some basic materials that you guys are going to need to check blood glucose. So the first one that I have here on the slide are lancets. And this is just an example of one. These come in different forms, so the ones that you guys have this week could look a little different, but the end of that tip there, the white tip on the lancet, is going to twist off, and that's what you're going to use to lance the finger or to prick the finger to get your sample. You'll also need a meter, of course, and again, this is just an example of a common one. Yours might be a little bit different. Just wanted to show you what these could possibly look like. And then you'll have your test strips here. You can see the top gray end is what we'd call the electrode end, and so that's going to go into the bottom of that meter down here, and then you'll be able to read your sample after inserting that. On the bottom end of the test strip, that's where the blood sample is actually going to go, and so there's just an example of that strip. Some additional materials that you need, and that I'm sure you guys will have on Thursday when you go to lab. You're going to need some alcohol pads to clean the finger, which we'll talk about in a moment, and then just cotton balls and band-aids, of course, since you'll be getting that sample, just to help patch the patient up afterwards. Next slide. So quickly, we'll go over some preparation for testing before we get into actual technique. Oh, I think we have a quick question, or oh, maybe not. Oh, we had a question. So preparation for testing. So first, always greet the patient and introduce yourself before you take their blood sugar. Let them know what you're doing and why that's important. Second, you're going to want to ask the patient some key questions before you take their blood sugar. So first, and one of the most important questions that you may want to ask them is, when is the last time that you had something to eat or to drink? You may also ask them what that was, right? So if they drank some water, is going to be very different than if they just had a soda. Also, you may, and like I said, the last time they ate or drank. So you may want to ask, was that 30 minutes ago? Was that an hour ago? Because that will affect their reading and what we expect, which we'll go over in a few slides. A second question that you may want to ask your patient is, do they have a diagnosis of diabetes? Because again, the reading that we'll get may be normal or abnormal depending on that diagnosis. So someone with a diagnosis of diabetes is going to be expected to have a different blood sugar range than someone that does not have that diagnosis. And then finally, do they have a latex allergy, right? Because we want to know if any of like the equipment that we're using, such as gloves that have latex, could affect them if they're sensitive to that. So that's just something important to note. And then next, before getting ready to test, you're always going to make sure your hands are clean. So sanitize them or wash them before you get ready to test, and put gloves on. Remember, we are dealing with a blood sample, so that's going to be important. I believe I have it on a later slide too, but I'll also go ahead and mention it here that it will be important to change gloves in between your samples as well. Next, you'll want to check the expiration date that's on your test strip container. So many meters and test strips have this code, and you want to make sure that matches up just to make sure you get an accurate reading. And after you take a test strip out of the container, also make sure that that container is sealed pretty tight as well. And you may want to check the expiration date, like I said, that's on that as well. So, and next slide. So now getting into, or well, before we get into testing technique, does anybody have any questions so far about just getting ready to test? Okay, pretty straightforward so far. So now we'll just get into testing technique. So the first thing you're going to want to do is select which finger is going to be tested. Who knows? Some people have a preference, and then some will just tell you whatever you think is best. So you're going to select that finger and wipe that with an alcohol swab. Preferably, it will be the middle finger or your ring finger here. And you'll want to try to avoid fingers that do have calluses, as those are going to be more difficult to stick. You'll also, of course, want to avoid smaller fingers, such as your pinky, just because that may be more painful for the patient. So sticking with those two fingers in the middle of the hand. Then after you have wiped that finger with the alcohol swab, you're going to want to let it dry completely. So that's going to do two things. That's going to help you get a more accurate reading, and also that's going to reduce any potential sting that the patient may experience. So just allow plenty of time for that. Then after that, you can insert that electrode in that was shown earlier in the material slide, that gray tip, to the end of the test strip meter, and then you're going to wait for this image of blood to appear that I have here on the glucometer and the screen. So you can see there's a little drop of blood, and that's going to signify that the meter is ready. And you'll want to go ahead and prepare all this, of course, before you stick the patient. Next, be sure to lance the finger on the side. Try to get the side or even slightly off center, not too much to the side, but just a little bit off. You'll want to try to avoid right on top of the finger or right in the center, because there are a lot of nerves there in the fingers. So that will help reduce pain for the patient. And next slide. All right, so to continue with our testing technique, so after you go ahead and stick the patient, be sure to wipe that first drop of blood. There may be more tissue serum in that sample, and that can cause some inaccurate results. So go ahead and wipe that, and then from there, you'll get your blood sample and bring that test strip towards that drop of blood, and then wait for the beep. So it's going to be important here. I wish I had an example here with me. But as I said, you'll just bring that test strip forward to the sample on the finger. Be sure you don't flip the finger over and try to lay it on the test strip or anything like that, because that could cause some inaccurate readings. Also, it may not pick up enough of that sample, so you could potentially have to stick the patient again, and we don't want that. After you're done with your lancet device, so you've lanced the finger, you've gotten your drop of blood, we heard the beep, and we're waiting for the reading. Go ahead and discard that lancet right away into the sharps container. And then for those remaining materials, like your test strips, your alcohol swabs, gloves, and cotton balls, those can all go in the trash. So as you can see here, you'll see a Sharpie, a Sharp A, and then sharps finally. So sharps the final image will go in that sharps container. Also wanted to mention that for blood glucose testing, you won't have to worry about having a biohazard container, since none of the materials that we have will be saturated with blood. You might just have a little bit on like the test strips, for instance, or a cotton ball. So those are okay to throw into the trash. Just be sure that lancet goes into the sharps container. Okay, so I have a question from Jenny. She said, how much blood is needed to get a reading? And that's a good question. It might be a little hard to show on here. I wonder if I'd be able to put like a little dot on a piece of paper almost just to help signify that a little bit. I don't know if this will help at all. Just like a small dot. So and it will help to be able to kind of pull back on the edges of the finger. So you'll be able to get like a little raised blood dot. So it might be about that far up, if that helps. I know it's kind of hard to show over Zoom, but you guys will be able to tell. You'll get the hang of it on Thursday. It's good that the blood glucose meters, they're different from some other devices, like when you test cholesterol, for instance, or you get readings from a patient that's on warfarin if you're testing those. So those require quite a bit of blood, but these won't require a significant amount. It should be pretty easy just to get that small drop, and then just use the meter to bring it up into that. And then the next question, oh, we have a couple maybe. Oh, no, sorry, it was just attached to that. The next question was, did we ask the patient if they're on blood thinners? And so for this, it won't be as important. You could, but it won't be as important for blood glucose, since the blood thinners, such as warfarin or some other anticoagulants, won't affect the blood sugar. They won't affect that reading. But it may be helpful to know, just for, should I expect this patient potentially to bleed a little bit more? So that's a good question. Were there any other questions before we move on?
Can you please go back to the slide where you can show us the stripe, which side goes into the machine?
Yeah, of course. So that gray part on the top, that's going to go into the bottom of the machine. And that little piece on the end, like that little strip, that's going to collect the blood sample. So as you can see, that's a pretty tiny little strip, so you won't require a large amount of blood for that. Just a good solid stick.
Do we need to wipe this the test strip with alcohol?
No, we won't wipe the test strips with alcohol, as that could potentially affect that reading. But we will wipe off the glucometer in between sticks for patients. We'll wipe the glucometer and we'll change our gloves. But you don't have to worry about wiping down the test strips.
There's a question in the chat. Oh, sorry.
Oh, it's okay.
There's a question in the chat about is stretching the skin around the finger the same thing as milking the finger?
That's a good question too. And I will answer that in just a moment when we get to the milking, if that's okay.
Cool.
All right. So we'll get into our tips for success now. So these first tips will help increase blood flow. So you may have some patients that come in and their hands may be very cold. You'll be able to tell very quickly as soon as you go to prepare them before testing their glucose. So here's some different things that you can suggest for them. If there is a sink available, they can go wash their hands very quickly with some warm water. That should help warm their fingers up. You can also just ask them to rub them together, which is often what I've done in the past. I'll either just try to rub the outsides of their fingers or just ask them to kind of move them around. And that'll usually help a bit to get the blood flow going. And then we'll also want to be sure that we stick firmly against the skin when you lance the finger. I know we never want to hurt a patient. We never want to cause them pain, but we do want to get a firm stick because as I mentioned earlier, what we don't want to do is have to stick them again. And I've had to do that in the past. So it's better to just get that firm stick the first time than have to stick them 2 or 3 times on another finger. And that's something important to mention too. If you do have to stick a patient a second time, go ahead and choose another finger. Next, something that would help for blood flow is just holding their hand below the heart, and gravity is just going to help there, help with blood flow. And then to answer the question that was asked earlier about is stretching, milking the finger. So here I've listed that you can gently massage the hand, so at the palm or moving forward towards the fingertip to potentially get more blood if they are a hard stick, but you'll avoid milking it. So when I say milking it, and this is probably going to look really funny, but avoid like pulling down on the finger. And that's more of like that milking motion. What I was referring to earlier is almost like pulling out a little bit just there on the tip to help push and get some more blood for that sample. So those will look a little different. So again, avoid that milking motion and pulling down on the finger, and it's okay to still press right there. Okay, thank you for the heads up. We'll finish in just a moment. All right, and then next, like I said, remember to let the alcohol dry and then just change gloves in between, wipe the glucometer down. All right, and next, reading the result. So here I've listed just a few parameters for your review. So this is how they could differ from that key question that you ask. Do you have a diagnosis of diabetes? So these are some values to expect when someone does or does not have diabetes. You can also see here this postprandial. So 2 hours after a patient's eaten, their blood sugar is going to look a little different than if they had been fasting. So if they had not eaten for a few hours, that's going to look different too. So, and I'll just let you guys just kind of look over these and feel free to ask any questions. But I'll move on to the next slide since I know you guys have class soon. Next, being able to identify hypoglycemia and then hyperglycemia, which we'll get to in a moment. So hypoglycemia, so some potential causes of a low blood sugar are going to be too little food or if they skipped a meal. If they are a diabetic patient, if they had too much insulin or of their medications, then that can lead to hypoglycemia. And it often occurs pretty suddenly. So these are some different signs and symptoms that you may see. They may be shaky, anxious, have a headache, irritable, and hungry, right? That would be reasonable. So these are some, you can go ahead. And then for hyperglycemia, so these symptoms can align a little bit with hypoglycemia, and that can be caused by the opposite things as I mentioned in the last slide. So maybe having too much food, especially sugary type of foods, too little of their medications, even illness and stress can play into this, and it can start slowly. Some of the very common symptoms you'll see for this is also extreme thirst, hunger, and having to use the bathroom pretty frequently. And next slide. And so finally, when to alert a preceptor. So if you see a blood glucose that's very low, which we would consider less than 50, with those signs and symptoms that I mentioned a moment ago of hypoglycemia, or if you have a blood glucose that's extremely high, so getting over 300 with those signs and symptoms of hyperglycemia, that's when you're going to want to alert a preceptor so then we can figure out our next steps because that patient's likely going to need additional care. And then finally, here's some non-pharmacologic recommendations. So often when you guys are out testing a patient's blood glucose, you may not be able to always make medication recommendations as you may have just met the patient and they are managed by their provider. But these are some things that you can recommend for all patients. And these are like with or without diabetes, it's going to be basic lifestyle modifications. So looking at their diet, salt intake, alcohol intake, and encourage increased exercise. You can also give them their blood glucose reading if you're out in the community and you had checked this at a screening. So encourage them to monitor their blood glucose if they have those resources, and then follow up with their provider with those readings. And I know we moved kind of fast at the end, but I think that's all we have for you guys. What questions do you have for us?
Thank you so much, Dr. Walsh and Dr. Strain. They both can be found in the Global if you have any other questions for them. So you can search them in the UAMS Outlook Global. So Madisyn Strain and Tyler Walsh. Thank you both for your time. We appreciate it, and have a good day. Have a good day, guys. I just sent Dr. Reinhardt a text, so she knows you'll be jumping over to class in just a second. Have a good one.
Thank you guys for having us.
Thank you.
Thank you.
Thank you.